afternoon, everyone. As the world is evolving every day, our healthcare is continuously advancing. It is important to keep ourselves updated on the latest clinical guidelines for accurate diagnosis, effective treatment, and to ensure that we are providing evidence based care that aligns with our current medical standards. Today, we have with us Dr. Lavanya Narayanan, consultant internal medicine and diabetes specialist, who will be sharing with us the latest clinical guidelines in hypertension management. Before we start our talk today, I would like to give a brief introduction about our speaker. Dr. Lavanya Narayanan is an internal medicine physician and diabetes specialist at KMI Taman Desa Medical Center, Kuala Lumpur, and also at Take Charge, a patient-centric coaching platform. She has a special interest in managing metabolic condition, including diabetes, hypertension, and dyslipidemia. She also has managed patients referred from across Malaysia for advanced diagnostic and individualized care. Her expertise as internal medicine physician extends to the complex diagnostics of adult medical conditions. Beyond clinical practice, she is also deeply involved in medical education and digital health innovations. Without further ado, let's welcome Dr. Lavanya Narayanan.
Thank you very much, Dr. Gauri, and I would like to thank Dr. Witty as well, Fiona, Ms. Louis from KMI, who has facilitated this session today. So just a very brief intro about me. My interest mainly is around non-communicable diseases as well as complex diagnostics, because that's the area that I specialize in. And today we will be navigating a topic where I believe is not much discussed, simply because there are a lot of evolving evidence that's going around. And I'm just going to I'm going to just summarize everything in this presentation. Okay, all right. So the discussion today will be, the presentation today will be on some updates on hypertension management. So as you all know, in 2024 and somewhere around early 2025, there have been some new guidelines that were published by the European Society of Cardiology as well as the American Heart Association and Cardiology. So the reason why these guidelines are evolving is because from the audits that have been done, we understand that the disease itself is evolving. A lot of lifestyle factors come into play, and how we approach hypertension as a whole is now slowly shifting. All right. So when we look at Malaysia, based on the National Health Morbidity Survey that was done in 2023, you can see the figures here. I've just plucked out the hypertension figures. About one third of Malaysians have hypertension, and if you notice, the awareness of those who don't know that they have hypertension is about 10 to 12%. And what's another stark information that we see here is poor target achievement. So almost less than half, slightly less than half of those who are diagnosed with hypertension on treatment, who are receiving treatment, are not able to achieve their target of blood pressure being less than 140/90. So that's quite a large number, meaning to say almost 1 in 2 people that are currently being treated, adults that are currently being treated for hypertension, are not achieving their target. And then the third thing that we notice also based on the survey with regards to hypertension is that we see there is a shift towards a younger population. So the biggest proportion of people who don't know that they have hypertension are actually within the age of 18 to 39. And that could be due to many reasons. Perhaps they are busy working adults, and also the standard perception of its hypertension is a disease of the elderly, which has been the how we approach hypertension previously. So that's going through a shift as well. Now, why update? We get to see that from that 48%, the number 48% that you saw, we get to see that there is a difference in terms of the guidelines that's available and what is really being implemented, or what is the reality that's being achieved on the ground. So almost 50% of them that's receiving treatment is not having a good control of their blood pressure. We see there is evolving evidence out there. So recent trials that has been conducted and globally has shown that a more intensive BP control helps in reduction in cardiovascular related mortality. So I'll discuss about intensive BP control in a bit. But we used to be a little bit more lenient when it comes to diagnostic thresholds as well as targets. But right now, the evolving evidence shows otherwise. Other than that, there is some discrepancies and differences within the global guidance itself that shows the targets, the diagnostic thresholds, as well as risk assessment when it comes to hypertension. And this varies across the two main guidelines that we will be looking at, which is the American as well as the European Society of Cardiology. So the Malaysian guideline is very much adapted towards the European guidelines. However, with a lot of evidence being shown in the American guidelines as well, I think as we are updating our clinical practice guidelines, it will be worthwhile looking at the changes on the American guidelines too. Another thing is that we also want to see how we, as Malaysians, are able to adapt these local guidelines that we will be working on in the next 4 to 5 years, because CPGs are updated every 4 to 5 years. They will be looking at how the local context is going to be adapting the guidelines that are being suggested by the global guidance, because the type of demography that they are looking at is also going to be slightly different from ours. So let's take a look what has changed in the global guidance. If you look at this table, you get to see the two main guidelines that I was talking about, which is the 2025 American Heart Association guidelines, as well as the 2024 European Society Cardiology guidelines. Now, the bolded figures that you can see here tell you that that's their diagnostic threshold for hypertension. Okay, grade 1 hypertension or stage 1 hypertension. See, previously, the diagnostic thresholds used to be 140 over 90. But if you notice for the American guidelines, the threshold has actually gone down to 130 to 139 or 80 to 89 being stage 1 hypertension. Keeping it less than 130 over 80, that would be considered as the elevated level or high normal or at risk. And anything below 120 over 80 is when it's considered normal and optimal. So anything slightly more than 120 or 80, you fall into the elevated category. But if you see the difference in the European Society's guidelines, you notice that the range for elevated blood pressure is actually quite big. So between 120 up to 129. So there's an additional 10 millimeters mercury for the systolic blood pressure, and also the same for the diastolic blood pressure. And the threshold to diagnose the hypertension here would be 140/90. So that's much higher. Now, so based on these key differences that we see, the American guidelines will probably potentially be identifying hypertension much earlier than the European guidelines. And at the same time, for the European Society guidelines, where they have a larger range of elevated blood pressure, which is from 120 up to 139. Now, this also can cause an effect in the way blood pressure hypertension is treated. So the takeaway here is the American guidelines will probably be able to diagnose more patients with hypertensions, and based on that, a risk assessment can be done earlier, whereby we discuss lifestyle as well as medication adjustment. Now, this is another preview of how these three guidelines are diagnosing. Okay, this is basically talking about the diagnostic threshold. Yeah, so you can see that ours, the Malaysian CPG 2018, is similar to the European Society of Cardiology, where the range of elevated blood pressure is actually quite big. Okay, about 20 millimeters mercury, as opposed to the American guidelines. Now, another thing that's different aside of a diagnostic threshold would be the risk stratification tools. So for practitioners who are constantly seeing patients with high blood pressure, I'm sure you all use the Framingham risk scoring, right, in order for you to see whether they fall in the category of low, intermediate, or high risk, to decide on how urgent or how emergent for you to start treatment for them. The American guidelines, they use the prevent tool, risk tool, and the European Society uses the score tool. So how is it different from the Malaysian guidelines that we follow, which is the Framingham risk scoring? Now, the Framingham risk scoring looks at general population as a whole. All right. But the prevent and the score 2 guidelines, they look at the cohort between a specific age group. So if you see, the prevent risk tool looks at the age range between 30 to 79, and for the score 2, it looks at 40 to 69, and for elderly, that means above 70 years old, you've got the score 2 OP, which is older population. Okay, because if we were to use the score 2 risk tool for risk stratifying someone, then anyone who's above 69 years old would be automatically considered as high risk just given their age, albeit they have any risk factors, other comorbidities or not. Something that is actually being done at the moment is looking at a score to Asia Pacific system, right? So the Framingham General Cardiovascular Risk Score now is slowly going to be evolving into a much more locally context risk stratification tool, which is the score to Asia Pacific. Also, what does this tool tell us? So if you were to just type in prevent risk tool on your browser, you get to see what are the parameters that's required, which is the standard, your non-modifiable risk factors such as your age, gender, as well as certain blood investigations like your HDL cholesterol, total cholesterol, the status of whether one is smoking or not, and some of it even would request for an eGFR, estimated GFR rate, as well as the HbA1c. Now, all this will then tell us what is the 10-year and 30-year risk of one developing atherosclerosis, cardiovascular disease events, yeah, such as myocardial infarction, strokes, and death. So we get to see the two different risk, okay, your 10-year risk as well as your 30-year risk. Now, what is considered high risk based on this would be if it's more than 7.5% of developing the cardiovascular risk diseases in a 10-year span, okay? And if it's less than 7.5, that would be considered lower risk. That is for the prevent tool. Now, if you're talking about the European Society that uses the score 2 calculator, then more than 5%, it will be considered moderate. Anything less than that is low, and more than 10% will be considered high. So this is something also that's different in these guidelines, if you notice. And we are following the Framingham risk scoring at the moment. But what is evolving here essentially is we got to understand that more and more of our population are being diagnosed diabetic at a younger age. So the risk changes as well. And on top of that, lifestyle and sedentariness related conditions like obesity, your BMI, smoking status, that too can alter the risk stratification by quite a bit. Now, the next thing that's different would be the treatment algorithm. Okay, so here we are still looking at global guidance. Yeah, so standard, we look at the BP classification first, whether, do they fall in the elevated category? Are they in stage 1, stage 2? If you look at the non-elevated category or high normal, both of these guidelines would recommend lifestyle modification first for 3 to 6 months. Okay, and if 3 to 6 months the blood pressure readings are still elevated, then they would consider evaluating their risk again and seeing if they are the low risk, moderate, or high risk, and deciding whether they require medication or pharmacotherapy or not. At the same time, while that is being done, we also have to look at whether are we excluding any secondary causes of hypertension. Okay, and that will be most of the time manageable or treatable. There will be specific tests that needs to be done, and with that modification, whether can we render normotension in this group of population. Okay, next would be stage 1 hypertension, because it is picked up earlier based on the American guidelines. So you see that would be equivalent to the European Society guidelines of elevated blood pressure. Here again, what is imperative is to do a risk assessment. So you use your risk tools again, and you see whether they fall under the low risk or the high risk category. So if they fall under the low risk category, then the guidelines recommend 3 to 6 months of lifestyle modification. So lifestyle modification here, there are few prongs. Yeah, importantly is implementing a healthy diet with a sodium restricted diet, which is less than 2 grams or 5 grams a day. The DASH diet seems to be something that is being emphasized on. Thirdly, smoking cessation, refraining from alcohol, as well as ensuring that sleep is well obtained and reducing stress as much. And importantly, physical activity, where now it's recommended, aside of just cardiovascular activities, you also have to include isometric resistance training as well as part of the physical activity component. For the high risk here, both the guidelines would suggest to initiate medications if they fall under the high risk category. We look into the type of pharmacotherapies that are recommended. For stage 2 hypertension, based on the American guidelines, and stage 1, based on the European one, goes without saying, where here you need a combination of both lifestyle changes as well as immediate drug therapy. Okay, now let's talk about the treatment targets. So we have looked at diagnostic thresholds, we have looked at risk assessments based on the different tools. Then we have seen an algorithm on at which point treatment is initiated. Now let's look at once treatment is initiated, what are the treatment targets? And here is where we can see the goalpost is slowly shifting. So for the American guidelines, if you notice, the general population of adults less than 65, the target would be less than 130/80. That's the standard that we are also practicing in Malaysia. Um, for adults 65 to 79 years old, it goes with less than 130/80. More than 80 years old or being frail, this is a special population group that we will look at and individualize. So in Malaysia, if they are very frail, very elderly, then the target, the cutoff would be higher, which is 150. Otherwise, we would aim for a blood pressure reading of less than 140/90. Diabetes and CKD, the target is 130, less than 130/80. But if they have diabetic kidney disease with proteinuria of more than 1 gram, then the blood pressure target will be less than 125/75. For post-stroke, it will be less than 130/80. But if you see the difference here on the European Society guideline side, the target for adults between 65 to 79 is kept at less than 140/80, right? As opposed to the American guidelines where it's less than 130/80. So this is where they find that a more intensive control would benefit the adult population even up to 79 years old, given that you are fit and you do have features of high risk of developing cardiovascular related disease. Okay, so the higher the risk, the tighter the control should be, and that is individualized based on your age group as well. Next, what are the drug choices that's available and what's different in these guidelines, right? So previously, beta blockers can be considered as first line monotherapy when we are managing hypertension, and that still stays the same for our CPG in Malaysia. But the American guidelines now recommend that beta blockers are reserved for those with specific indications. That means they have hypertension with heart failure, hypertension post myocardial infarction, or hypertension with atrial fibrillation or sympathetic drive. Yeah, so that would be the focus for beta blockers. Otherwise, we can go with the standard monotherapy, where we start for patients at stage 1 hypertension with ACE inhibitors or ARBs, calcium channel blockers or diuretics. For stage 2 hypertension, it is recommended based on both the guidelines that we look at combination therapy. Okay, so that means we start off with a single pill combination or initial dual therapy itself. So sometimes in the MOH formulary, it's difficult to get a single pill combination. We can still use the same principle and give them separate pills, but we initiate dual therapy at once. And this is mainly to tackle the renin-angiotensin system. That's where it gets inhibited. Other than that, you can combine the ARB or ACE inhibitors with CCB or ARB ACE inhibitors with diuretics, depending on the preference, as well as if they are able to tolerate the calcium channel blockers or not. If they if you're moving on further, despite being given the dual therapy and still the hypertension is difficult to control, then you add on the third therapy. So this is a bit different from how hypertension used to be managed, where you start monotherapy at the beginning itself, regardless of which stage you are in, and then you monitor, and then you titrate up, or you increase the dose first and then you add on a second therapy much later. So if you notice that from a single therapy, a patient might take up to 8 to 9 months before a second tablet is added to them, a second line of treatment is added for their therapy. So this gives like close to 8 to 9 months of still suboptimal control of blood pressure. Okay. Next, let's take a look at clinical applications. So what are the actionable steps for us practitioners when we are seeing patients in the clinic? So of course, if we see patients that are previously not diagnosed with elevated blood pressure or hypertension, based on our CPG itself, we have got a guideline on who to screen and what entails in the screening. So importantly, anyone above the age of 18, or if they have got a strong family history of similar conditions, comorbidities, then it's good to screen and monitor if they have hypertension. So a one-off reading may not be sufficient, but it's good to just identify if they are at risk of having hypertension. In the clinic, what you can do and what counseling you can give your patients would be the way we measure blood pressure itself. So as soon as the patient enters your room, you got to give them at least 5 minutes. I'm sure most of the time the blood pressure recording has already been taken before the patient walks into your room. But perhaps you can consider checking a blood pressure after 5 minutes in and ensuring the cuff size is correct. They are seated with their legs on the floor. They are rested, arm at heart level, and to be very specific, an average of 2 to 3 readings should be taken. Okay. To confirm hypertension, now this is where the challenge really is, because unlike diabetes, right, there is actually a cutoff number that we see on blood parameters for us to decide whether this patient is pre-diabetic or diabetic. But in hypertension, it's more of a very silent situation, and it is affected by multiple factors. So that is why, even though mercury sphygmomanometer blood pressure recording is the gold standard, now guidelines have also recommended electronic blood pressure monitoring systems. And what is more important here is the data points. So you can't just have one or two data readings and confirm the patient having hypertension. But what you can do is have as many data points as possible. So the most practical method to do this is, of course, to have them monitor their blood pressure at home. So out of office measurement, because we do know this existence of what we call white coat hypertension, or even masked hypertension, where the blood pressure is normal in the clinic, but then it's elevated outside. Okay, so ambulatory BP monitoring is not something very feasible. If it's available, it can be done, but home BP monitoring is very feasible. Documenting the BP classification now is be very important. So I hope after this, even this is all going to be changing the way we manage and monitor hypertension, is that each time you see the patient in the clinic, we just don't want to end with the term hypertension. We want to be able to state which stage of hypertension they belong to and what is their risk like, or if they fall in the category of elevated blood pressure, so that we know the progression of the control of this condition, and it's not just based on recordings of the blood pressure. Next would be initial labs and tests. So what's really new here is that we are encouraging urine albumin creatinine ratio to be done early. This is to identify presence of kidney disease. And a group of them lately, I think in the European Society of Endocrinologists, if I'm not mistaken, have published a guideline recommending that all patients with hypertension should be screened for primary aldosteronism. Okay, so how do we screen them? We screen them with plasma aldosterone renin ratio. Traditionally, it's told to us that this is a very tedious process where you have to ensure that patients are not on certain medications that are potassium sparing, because this can alter the renin and angiotensin system, and you have to make sure that the potassium levels are between 4 to 5 to get an accurate reading. But I think the guidelines are moving towards a little bit more leniency, whereby the medication list does not matter as much as long as you don't have direct potassium sparing agents such as your spironolactone, for instance, or ACE inhibitors, ARBs. But other than that, aside of just ensuring that the potassium levels are within range, then you can proceed with sending off a plasma ARR. Then from there onwards, if it's elevated, then they will look at doing a saline suppression test, or referring to the endocrinologist for adrenal venous sampling, as well as a CT scan of the adrenal glands. But what's important here at our primary practice level, right, is to ensure that looking at whether the elevated blood pressure has done any damage to our system or not. And that starts with identifying target organ involvement, right? So your kidney function goes with your urinalysis, your early urine protein detection, checking your cardiovascular system with your ECG, stress ECG if possible, going with other comorbidities checks such as diabetes screening, and also dyslipidemia, because this altogether increases the risk of MACE. And next, not forgetting secondary hypertension screen, where we look at their medication list. So many at times we kind of omit certain supplements or certain over-the-counter medications that patients take quite often for pain management. So steroids, NSAIDs, yeah, even OCPs. These are closely related to elevated blood pressure. So that has to be looked at. Renal disease history, they've got a history of renal parenchymal disease. Family history of any specific inherited conditions like ADPKD, for instance, sleep apnea symptoms, as well as endocrine symptoms. So it's important, I mean, if it's the first time you're seeing the patient and diagnosing elevated blood pressure or hypertension, it's crucial to find out, because most of them actually have a rather normal body morphology or phenotype. For instance, in primary hyperaldosteronism, they tend to look a bit, they appear normal, they appear just fine, but they have elevated blood pressure. And upon doing the test is when you find out that there's a mass that's requiring treatment. Okay, and with all that, we then have to look at the risk assessment. So that is step number 3. So once you suspect, you do your assessment, which includes this 4 prongs, and then you risk assess the patient. And based on the 10 years CVD risk is where you decide, whether the patient requires treatment, pharmacotherapy or not. But what are the red flags for immediate action? So if a patient comes in with blood pressure of 180 over 110 or 120, then you know you're dealing with some form of hypertensive crisis, right? Identifying whether this is just severe hypertension or whether this is hypertensive emergency is what you need to, be comfortable with. If it's an emergency situation, then you need to bring the blood pressure down much faster within 24 hours. But if it is just severe hypertension, which is asymptomatic most of the time, then the guidelines actually recommend monitoring the blood pressure over 2 hours. So you take the blood pressure reading every half an hour for 2 hours. And if it comes down, then you can suggest oral pharmacotherapy for better control later and get a specialist clinic appointment. Otherwise, you start them on dual therapy, combination therapy itself. But that is not immediately, but you allow the patient to rest for half an hour, and then you measure that back the blood pressure. If it's still persistently elevated above 180, 100, then you initiate treatment. Next would be how this is applied in clinics, right? This 10 years CVD risk calculator. I think we just should pick up a calculator that we are comfortable with and adapt it to our local practice. So we have got the prevent equation, we've got the score 2. Score 2 Asia Pacific is still in progress. And we've got the Framingham score that we are currently using in Malaysia. Whichever scoring system that we are using, essentially that we want to see if they fall under the category of high risk or not. And if you look at all these calculators, as soon as one is identified as CKD or diabetic, or dyslipidemic, then they actually, with CKD, then they fall in the category of high risk already. Next would be lifestyle and pharmacological start points. So I'm just putting all the three guidelines side by side to see where is it differing from the standard practice that we are doing right now. So all of them, of course, universally, lifestyle changes is important. And then for the American guidelines, if you notice, in the category of elevated blood pressure itself, here medications are recommended if lifestyle modification measures fail after 3 to 6 months of monitoring. Okay, that's where they initiate treatment a bit earlier. Selecting therapy, whether it's combination or monotherapy, now this again will depend on which stage of hypertension one is in. If it's stage 1 hypertension with low risk, then you can go with monotherapy and monitor. And how is it changing our management today is because very often when we see patients in clinic with a blood pressure of, let's say, 148 over 92, we initiate one therapy first. Yeah, so the guidelines actually recommend a combination therapy because they work synergistically. They work on multiple ways, such as aside of reducing vascular resistance, they work on the RAS system. They work on, like SGLT2 inhibitors, for example, as an adjunct, helps with osmotic diuresis. So it reduces the absolute blood volume itself in the system, and that way it reduces the blood pressure by at least 5 millimeters mercury when it's added together. So do consider a combination therapy. Don't worry too much about the blood pressure dropping very significantly. So that is why it's important to first see which stage of hypertension they belong to and what is their risk state like. Okay? If they are high risk and they are in stage 2 hypertension or BP persistently, most of the days is above 140/90, then you are quite confident that they will benefit from a single pill combination or a dual combination therapy. What are the preferred antihypertensive agents in Malaysian practice? So we always resort to our easy renin-angiotensin system blockers, which are our ACE inhibitors. We've got ARBs as well. One important thing to always ensure is when you initiate patients on this treatment is to follow them up in the first 2 weeks at least to have a look at their renal function and see if there's any deterioration. Younger patients with bilateral renal artery stenosis tend to progress very badly if they are started on ACE inhibitors. So it's important. That is why we catch them early to monitor and see. Look at the potassium levels as well. Some patients don't tolerate ACE inhibitors due to dry cough, so you want to think about an alternative, which is ARB. And we don't start these medications in patients who are pregnant. We avoid them. The standard drug of choice for pregnancy-related hypertension will be metal-dopa or beta blockers. Okay. Calcium channel blockers, such as your dihydropyridines, are used very widely in Malaysia, so that's available in MOH and even in the pharmacies outside. Here, what you got to make sure is that they don't suffer from complications like pedal edema. So many times people get confused whether this is heart failure or whether this is related to medications. Later, when you look at the list, is where you get confident that they have no features of heart failure except that they have lower limb swelling. They tend to have sometimes some stasis eczema. And that is something to take note of when you're following up your patients. Okay. Thiazide like diuretics. Indapamide, interestingly, is preferred in Malaysia from what my readings. But in practice, what I've seen on the ground, people tend to lean towards hydrochlorothiazide. So an important thing to take note of is those who are elderly, who are started on hydrochlorothiazide, ensure that you follow them up. Always check their electrolytes as well as their uric acid level because it can lead to hyperuricemia. Now, the role of beta blockers are slowly changing as well in Malaysia. So, for ESC and American guidelines, they are currently no longer the first line treatment, but in the Malaysian guidelines, you see that there is an exception. We prefer beta blockers in a certain group of people. Younger patients with maybe a sympathetic drive, those with unexplained tachycardia or atrial fibrillation while being worked up, yeah, and those, of course, post MI or those with heart failure. What about the special population groups, such as those who are diabetics with kidney disease as well as stroke? Now, standard-wise, for the American guidelines, they recommend the target to be less than 130/80 throughout. So you can see all three population groups. less than 130/80. For diabetes, if let's say a patient is found to be hypertensive and also has diabetes, straight away go with dual therapy with the RAF blocker. So you must have the RAF blocker component in there because it helps with ensuring that the patient doesn't develop proteinuria, or if they have proteinuria, it helps with reducing that. At the same time, it also possesses properties to reduce blood pressure too. Chronic kidney disease, unless contraindicated, we still go with ACE inhibitors and ARB only if there is a sudden increase in the creatinine levels indicating AKI more than 30%, then we would, from the initial creatinine levels, then only we would temporarily halt ACE inhibitors or ARB. Okay, most of the time, the AKI is not caused by the drug itself, but there will always be something that is concomitantly on the patient, like maybe NSAIDs, maybe some other medications, traditional supplements, or patient might be just feeling unwell, dehydrated. Those might be the reasons why you see AKI in patients with ACE inhibitors or ARBs. For the European guidelines, if you notice, most of the targets are also less than 130/80. So you see their target is 120 to 129, which means less than 130. And similar goes for the diastolic blood pressure as well. For the stroke and TIA, it's also less than 130/80. Like I mentioned, in Malaysia too, the guidelines recommend um, less than 130/80 in certain groups, special populations like diabetes, with kidney disease, those with stroke, that would be our go-to number. Those with significant proteinuria, we would be a little bit tighter with that, which is 125/75. But by and large, the target blood pressure based on the Malaysian guidelines would be less than 140/90, which is not, I think, not very difficult to achieve. And despite that, we still see almost 50% of patients being treated not achieving their controlled blood pressure. How about management of patients in the older category and frail patients? Now, this one we have to be a bit careful because in the category of geriatrics itself, we have the fit geriatrics and also we have the frail ones, or with multiple comorbidities, those who are undergoing intensive treatment, maybe for chemotherapy, undergoing chemotherapy or long-term therapies. So here, all three guidelines, they recommend individualized therapy. You still start, you still go slow, but you go. That is the idea. Because guidelines, based on the evidence that they have gathered, with control of blood pressure to a certain extent, they do see benefits. Okay, so these two guidelines recommend keeping the blood pressure less than 140 for patients who are above 80 years old or frail, where we have to look at any adverse effects. The diastolic blood pressure is also something quite important, for the elderly. Why? Because when your heart goes into diastole mode, that's where your coronary perfusion actually gets activated, right? So if your diastolic blood pressure is too low, then that would also compromise the coronary perfusion. So we try to ensure that the range is between 60 to 70 millimeters mercury and not lesser than that if we are trying to get an intensive control. For medication considerations, I think it's extremely crucial to reduce or avoid polypharmacy, because we have a tendency to add so many classes of medications for the patient. Always look at what is the main issue they have. Is it heart failure? Is it a post-stroke? Is it a post-MI? Do they suffer from palpitations or tachycardia? And at the same time, if you can find an alternative or an option where it can be in a combined pill form, that would be great, because this improves adherence as well and reduces complications with medications. Benefit risk assessment. This is something that I think we don't really get much time to do if we're not in geriatrics, but if you have your time with patients, I think very importantly, document their functional capacity. Okay, as to what are they able to do when it comes to mobility work, when it comes to all the small motor, the fine motor work, and whether do they have any visual spatial disturbance or not. Visual spatial disturbance here means that they are not aware of where they are, they're not aware of where they put things. So all these things actually indicate that there is a progression towards dementia. And when that kicks in, then all the other motor functions also decline, and that can lead to problems like fall. So that's very common in the elderly population, and you don't want your medications not revisited because that can further add on the risk of falling. So follow up and monitoring, these are some strategies I think we can try to apply in our practice. This is not a single person's job, just like managing diabetes as well. This requires a team in order for us to actually achieve our KPI of making sure that they are within control, or maybe even considering stepping down treatment later on. Always when you see our patients over and over, risk assessment needs to be looked at again. And for the initial stages, when we are making some changes to their treatment, it is advisable to see them at a nearer interval, maybe 2 weekly or 4 weekly. Until you're comfortable with the readings, then you can go with 3 to 6 monthly. So there are certain applications where doctors can also use to monitor patients' blood pressure. Like Google has their own fitness method on their platform. Then we have My BP app that also helps to record blood pressure readings in the system, and it also gives them like a color coding: green color, yellow color, red color, yeah, alarming features, etc. Aside that, this helps the doctor also decide on most days at home how is the patient's BP control. So that is a good way, using technology in monitoring non-communicable diseases. Other quality improvement strategies that can be also utilized here is having an audit and feedback system. In this way, we can look at our clinic database and see where is the pitfall, which category of patients are falling off, and why is that the target is still not met. And that way we can improve the way we work. Medication management, suggesting the Medibox system. Some are even geared with some batteries and a monitor where it tells you how many pills left, if you're missing out something, and alert. So those are all very high tech stuff. But as simple as a simple Medibox with the medications in there labeled will really do good. What the doctors can do is switch to single pill combinations. This will help improve adherence. And what's good out there is that for the single pill combination medications, there are a variety of doses that's being combined. So you have from the lowest dose to the highest dose in combination of each medication. So multiple permutations of that medications exist, and I think that's very helpful for the doctors. A team-based lab care, so you have your nurse to take the blood pressure and to record the blood pressure in the system. That way, you can save time and you can speak to the patient, perhaps chat a little bit more with them. Community outreach programs. So these are just overall improvement strategies that we can do to tackle hypertension as a whole. Because, like I said, hypertension itself is, by and large, is a very silent disease. Yeah. Very vague symptoms they come with, such as neck pain, maybe some giddiness, headaches, unable to sleep at night. So most of the time it's overlooked. And we really sometimes really struggle whether is that the effect of what they're experiencing, or is that the cause of what the symptoms are. Next is when to refer. So this is where I think it's important for us to know at which point we require escalation of care, or co-management with another practitioner when it comes to optimizing their blood pressure. So you have three categories here: those with suspected secondary hypertension based on your clocking and your assessment. Urgent referral is indicated for those with hypertensive emergency. If you suspect pheochromocytoma, I think this is something that we need to read about. Pheochromocytoma, even though it is a rarer situation amongst the endocrine pathologies, but there are a lot of patients with endocrine disorders that present with hypertension, and it's not Cushing's, it's not hyperaldosteronism, it's not OSA, it's not acromegaly. We tend to miss out pheochromocytoma because it's rarer. It requires certain type of blood parameters to be checked as well, like your metanephrines, and then you need to do a imaging study to confirm. Hypertension in pregnancy requires urgent referral to the specialist, and those with young hypertension, because this most of the time it is there is a secondary cause. Priority referrals, hypokalemia, those who have hypokalemia who are not on diuretics. So there should not be a reason why a patient is hypokalemic if they are not on diuretics, if there is no GI losses, if they're just very well. But if they're persistently hypertensive, then you think about primary hyperaldosteronism. If there's any episodic symptoms suggesting secondary causes, such as pheochromocytoma, you will notice that the nature of headaches and the nature of the abdominal pain they get is very episodic, it's paroxysmal. So that is something to take note of. Abnormal hormone screening results. I'm sure a lot of your patients actually go for a complete hormone screening test just to have a look and see if there's anything wrong. And if you find something that's abnormal there with regards to the blood pressure control system, then I think it's important to take note, as well as if there's significant BP variability, if you notice. For resistant hypertension, this is defined by having persistently elevated blood pressure in the hypertensive category, despite being on at least three antihypertensives. So that it will be an indication for you to refer. Some patients actually benefit from renal denervation therapy, but that is something that we are still, researching and looking at. We manage with the nephrologists as well. So they denerve the supply to the kidneys, and that helps with reducing the blood pressure as well. And organ damage, those with heart failure, any neurological symptoms, kidney disease, as well as retinopathy. I think this goes without saying. You need to escalate and ensure that the cares are given accordingly. So for the Malaysian context, what's practical for us? Here we see comparing just the CPG with other guidelines, our diagnostic threshold is quite way higher. So maybe a take-home message from this analysis, what we can do is moving forward when we see a patient with an abnormal reading of blood pressure, we need to be sure whether are they in the elevated blood pressure category or not. Because that's similar to pre-diabetes. Previously, it was just diabetes or not diabetes. Then came in the pre-diabetes category, and that gave a lot of awareness to people to screen, also to look at risk factors, and for them to be diagnosed way much earlier. That reflects in our statistics as well. That's why we see a huge shift towards the younger group of people having pre-diabetes and diabetes. I think the similar principle can be applied for blood pressure measurement management as well. Risk assessment tools, currently we are using the Framingham cardiovascular risk scoring. It's not wrong, it's not bad, it is good, but I think we have got some other things to compare with. So maybe what would be really interesting if you have time is for that very same patient, you utilize the three tools and you see how far different are they. Do they all categorize the person as a high risk? If they do, then that's good. Is there discrepancies that you see, and why? What are the factors that is putting a person at a higher risk for a specific tool and a lower risk for another tool? Are we under stratifying our patients or not? BP targets for now, we are keeping it at less than 140/90 as opposed to global guidelines, which suggests much intensive control. Beta blocker roles, we see it as a potential first line option still based on our guidelines, but in the global guidelines, they are de-emphasizing this and they are looking at only a specific group of population for beta blockers to be initiated on. Combination therapy, in our setting, we go with a stepwise approach where we start monotherapy, we monitor, then we up titrate, or we add on a second agent later. Combinations are only given for higher stages of hypertension, but here earlier initiation of dual therapy is done and a single pill combination is preferred. That's how we just head to head compare between these guidelines that we have. In terms of Malaysian formulary and drug access, we can see that these are the four categories actually, the monotherapies, and then we have the combination therapies. ACE inhibitors are relatively cost effective, they're cheap. ARBs are a little bit more expensive, but they are very much available as well. CCBs are very commonly used, widely available in MOH facilities as you can see. Diuretics and beta blockers, and this is also very accessible. Single pill combinations, now this is where the problem lies. Yeah, so there are limited options that's available, they are all within quota. But I think if the patient really would benefit from that specific combination, that the role of the doctors are to identify who are these patients, which group they belong to, what sort of risk are we dealing with, and perhaps request for it. So these are the clinical benefits that you can see with single pill combinations. I've explained this. Moving on, what works for our Malaysian clinic? this is the recommended workflow for us. We can do a pre-consultation screening. Maybe we get some information about the pre-existing blood pressure levels that the patient has. This gives us an idea what we are working with instead of seeing them the first round and then having them to record it later. So you're even delaying by a month. Risk stratifying them each time they come. So we understand if their risk status has moved, standardizing a follow-up system for them, and integrating the pharmacy support as well. So in terms of staff roles, I think there's a few allied teams that we need to closely work with, which are the nursing staff, the pharmacy, the medical officers, to train them and identify at which point escalation of care is required and how do they co-manage, and when de-escalation of therapy is done, how do they take on from there and then continue on. Technology integrated tips, this is very underrated. Okay, so I think this is something that we all need to start applying in our practice. Having perhaps an EMR that is already existent in your system helps to categorize patients, have a screening tool embedded into your EMR system, so it's easy for you to do your stratification there. Also offering telemedicine services or medicine clinics. Barriers to effective BP control, we know there are three main barriers: patient barrier, system, and resource. So which are the barriers we can tackle? I think the simplest one we can work on would be our patient-related barriers as well as system-related barriers. Perhaps resource-related barriers is something that most of the time is not within our control as practitioners in the clinic. And quality improvement ideas where we take note of audit and feedback cycles. So if you run a chain of clinics, I think it's good to look at the audit for the hypertensive patients to see where you're standing. Digital BP logs, telehealth, getting the community engagement, because awareness is still very much lacking when it comes to treatment and management of hypertension, as well as ensuring that you have a dedicated team care based model existing in order for you to be able to increase the control rate of patients with hypertension. These are some quick references, cards that will help you with approaching a patient with high blood pressure. Um, this is a card when to see a specialist. Maybe if you all need the slides later, I can just share that with Dr. Witty. And these are just some important tips. You can identify which require urgent referral, semi-urgent, and routine, as well as the overall comparison for the three guidelines that we were talking about. I think it's important just to be well, exposed to what's going on around us, right? Because our guidelines last was in 2018. I think the next would come in the next 1-2 years. But we need to know what's continuously changing, and importantly is how do we adapt that in our local practice? Yeah, does that make sense for our local setting? These are the references I used for this analysis: the American guidelines, the European, and the CPG of Malaysian Health, Malaysia Hypertension. Other supporting evidence, we looked at a few trials, as well as the online risk calculators that I spoke about. So if there are any questions, perhaps I can just run through them quickly. Okay, we have got one. Would you treat a 74-year-old female patient with a BPL 140 to 50, 70 to 80, otherwise healthy, with a good active lifestyle, no other health issues? In patients with central hypertension, why doesn't the ARB work as well as they do as patients with essential hypertension? Okay, maybe I go with the first question first. So again, when we are looking at treating hypertension itself, right? I think risk stratifying the patient is very important. So otherwise healthy with very good active lifestyle, that maybe the take home there is the patient doesn't have any other comorbidities, just high blood pressure alone, I presume. Yeah. So that would put the patient at a lower risk, right? And the guideline states that we keep it less than 140/90, right? Isn't it? Yeah. Only for those above 80, we can allow up to 150. So if most of the time the patient is well, asymptomatic, it doesn't carry the risk of developing an immediate cardiovascular risk or disease, then I think lifestyle adjustments alone should be helpful. Because with lifestyle adjustments, right, when it comes to the choice of meals that they take, maybe just by reducing their salt a little bit more, having good sleep, ensuring all the other things around them is managed, I wouldn't rush into treating. But yes, I would monitor, and I would see if I persistently note that their blood pressure recordings are above 150, 90, then that would be something that I will take note of. Yeah. Did that answer your question?
Thank you, Dr. Lavanya. We have a second question. In patients with central hypertension, why doesn't the ARB work as well as they do in patients with essential hypertension?
Mm, I'm not very sure if they don't work as well. Is there any evidence that states that they don't work as well for central hypertension? I'm not aware of that. I'm sorry. And when we say central hypertension, may I ask Dr. Jayanti, what exactly are you referring to? Are you talking about secondary hypertension or other causes of hypertension? Okay. Um, So, essential hypertension is a diagnosis of exclusion, and also it's a diagnosis where we can't find any other reasons to why the person has high blood pressure. I presume the other option here is secondary hypertension, because those are the two large categories that we deal with now, isn't it? Secondary hypertension and primary hypertension used to be known as primary or essential hypertension.
Hi, Dr. Jayanti, would you like to add on your question? Okay, we have another question. Oh no, we have Dr. Sophia.
Oh, thank you. Thank you very much.
Okay.
So it's not really a presentation to teach how to manage hypertension. Like if you notice, it is just to give you all a bit of awareness of what's happening around us. Because most of the time we are so engrossed in our work inside, and we don't know what's happening around. And these guidelines, they are like 500 pages, right? So sometimes having a refresher on these updates will be useful for us, and to see whether our updated guidelines for Malaysia's TPGs, will they be adopting these changes soon or not? I think it's important lah, where the threshold is shifting, that makes us a little bit more aware on the at-risk group. Okay, maybe we can reach out to Dr. Jayanti later and clarify on the question. But if there are no other questions, I would like to thank Dr. T once again. Thank you, Dr. Gauri, for moderating the session. And thank you, KMI.
Thank you, Dr. Lavanya, for the very insightful talk.